Now I'm going to present the fourth case that we have, the fourth and final case. We have a 73-year-old male today with no diabetes or hypertension, but he is an ischemic heart disease patient. The patient has a history of hematuria and abdominal pain that started 2 months ago. The labs show a total bilirubin of 10.27 and a direct bilirubin of 7.29. The ERCP showed a high up obstructive jaundice, a plastic stent that was placed inside in the CBD. The CT was normal with stent in place. The EOS showed a common CBD mass that was 1.3 by 1.2 centimeters, portal vein thrombosis, stent in place, massive ascites, lymphadenopathy, and mild intrahepatic biliary radical dilation. Today we're going to perform an RFA with cholangioscopy, and I'll go to room 1 with Dr. Mostafa and Dr. Hany.
Okay, good morning from Egypt, good evening from Malaysia. So first of all, I would like really to thank you very much for such a great invitation and great opportunity. So as you heard, here I'm in our center. This is our first case. I'm working with my everyday team, so controlled by our head nurse Salma, and very good control by Professor Hany Shehab, I think the best cholangioscopist in Egypt. So as you have heard the patient, so this patient had a plastic stent which I already removed, and now I will cannulate to put the spy. So my plan is to put the spy, and then after that to be able to check this CBD structure or CBD mass, take biopsies, and then maybe doing an RFA for the lesion after biopsy. So yes, we will just cannulate.
So yes, in this case, Mostafa will do it differently. He'll put a guide wire first. I think this is always prudent and safe, and it actually saves time. To put a guide wire, it makes the introduction of the spy
visceral gene
and safer actually.
So I'm using as most of you maybe my friends knows, I'm the student of the VR. So I'm using always a cannula in the first, and then if I'm not able to cannulate easily, I will shift to a sphincterotome. I'm using a standard cannula from Boston Scientific, and I'm using the new duodenoscope, the 500 XT, 580 XT from Fujifilm. Also, I'm using today the new guide wire from Boston Scientific. So you can see this is the previously papilla. I will shift a little bit to the left. There's a lot of secretion. I will do aspiration a little bit, and then try to cannulate.
This is one of the many differences and fights that me and Mostafa have. He's a very classical endoscopist. He always likes to use a cannula, even though I think many studies have shown that if you use a sphincterotome to do guide wire cannulation, it's actually easier. But again, I think it is a point of debate, and many endoscopists still like to use a cannula.
For me, this is a very good debate. We always have this training courses when we do me and Hany together, and I have learned endoscopy in a place where if you cannot cannulate by cannula, you should not cannulate by a sphincterotome. This is not my daily practice now. Yes, it's easier to start with a 3-lumen sphincterotome. However, one of the good things I think to use the cannula, that this will just help you to have more and more control on your scope. Can I have Bascopan, please? Thank you. Okay, there is a little bit of peristalsis. I will inflate a little bit. We need just to see. So what do you think about the idea of doing RFA in this patient, where we don't know really the origin or the nature of the structure?
I think yes, it's a point that I think many of the viewers might think that this is arguable or debatable, that you do RFA and you still don't have a definite pathology. But actually, what supports this is that of the many studies that have been done on RFA, of course the safety profile is actually excellent. I mean, the reported complications of RFA are minimal. And secondly, there have been case series and reports on the use of the RFA even in benign strictures. They have been shown to have a beneficial effect. I'm not sure what is actually the mode of action of RFA in a benign stricture. It is supposed that it reduces the fibrosis. It modulates the immune response in this area, so it reduces the fibrosis in a benign stricture. So anyway, so whether it is an actual benign stricture or it is an actual malignant one, I think RFA in both cases will be warranted. This is our idea. Yeah.
Yeah, but if it is benign, you have an alternative that may be even more effective. On the other hand, I agree with you that if it is malignant, RFA is extremely safe. So I guess that with cholangioscopy and the biopsy, you can have a
X-ray. X-ray.
Yeah, I agree. Yeah, the problem is that still I think all of us agree that in many cases we still cannot reach an absolute diagnosis using the pathology. We still know that the SPY bite has an accuracy of about 70%. So you will miss 30% of malignant cases. So we still, I think all of us, sometimes we depend on your clinical impression, whether this is a malignant tumor or a benign one.
Okay, so yes, sorry, continue, sorry.
So yes, I think we will do in all cases, we will do a SPY bite to know the result. But the outcome, I think in both cases is similar. I think this man, in any way, he's not an operable candidate. He will have a palliative treatment for his condition.
Yes, you can see here now. I think we are already inside the biliary system. If you just in the middle of the CVD, we have this irregularity. So I already put my guide wire deep inside. I injected contrast. What I will now do, I will exchange my sphincterotome and guide wire and put the cholangioscope, the spyglass, and then we will assess this type of lesion, and then we will see. So I will exchange. I'm using also this new guide wire from Boston Scientific, the Jaguar Revolution, which is also very good sometimes in doing this right and left manipulation to go in the right biliary system and left biliary system. So as you can see, I'm using my patient, I'm putting my patient supine position. This is always, I'm also, as I said, I'm this from Kramer school to use always the supine position. The patient is intubated. So we are exchanging now, and then I will put the SPY immediately. Yes.
So you can see that we have a stricture. It's not too short. It's I think it affects the common hepatic duct. It's about 2 to 3 centimeter in length. It seems to be tapering.
Yes.
I'm not sure that we can of course give a solid impression of whether it's benign or malignant. Dr. Cesari, what do you think? Would you give an impression on this cholangiogram?
When considering also the clinical history, I'm not so confident it is benign.
Yeah.
This is my feeling.
Yeah.
It looks as a very long sticker, right?
It seems to be long, yeah. I think about 3 centimeter in length. It's affecting the common hepatic duct. If we would classify it, I would classify it as a bismus 1. I think that you do have a free bifurcation.
Any endoscopic LASAR performed before?
Any endoscopic picture you see? EUS.
No, we didn't do EUS for this patient. So it was only diagnosed by MRI and MRCP, and then he did in another hospital the first ERCP, and yes, and was referred to us for the cholangioscopy.
But I agree,
Oh,
and
screen كده.
US of course will add to the clinical picture, of course. I think maybe like 5
خليك-
years ago you would have said no, this is
خليك معايا بس.
a hilar stricture or proximal stricture, so it's not for EUS. But I think now most of us agree that EUS does have a role even in these proximal strictures. So yes, I agree, it could help. But of course we feel that a spyglass will go ahead.
What is the accuracy of cholangioscopy in differentiating between benign and malignant in your experience?
Okay.
This is a good one. This is a good
It's a
one.
good question, and I think it's a point that's not settled. The literature says that according to your visual assessment, you have a very high accuracy rate, over 90%. But the spy bite results, but these are results all with the previous spy bite, not with the spy bite max. They say that you have a sensitivity of about 65 to 70%. So in my experience, I always, yes, I do have an impression, but it's not as accurate, and I wouldn't even say that it reaches 90% accuracy. I have to be honest. And as I said, I think we are still far from having an accurate diagnosis. I mean, we're far from reaching the level that we've reached in the colon, for example. In colonic polyps, we can really assess with the pseudo-optic pattern and so on, and with the MBI, and you can visually assess. But I think in spyglass, at least this is my experience, I'm never confident enough with my visual assessment. I'm not sure if your experience.
And do you feel that artificial intelligence
Ah. Yes. My opinion, yes. I think, and I know that this will be coming soon to the cholangioscopists. I think yes, if we can see a stricture and then just push on a button to assess really the type of the stricture, and then let's say our AI will guide us to the best part to take a biopsy. I think this is a very good example.
Yeah.
I would love to have it.
I think it's a perfect application for AI here, because really we need something to help us, because our eyes alone are not good so far to differentiate.
So I think so first of all, so this is your next guideline, Cesare, huh? So this will be your next guideline, AI in cholangioscopy, yeah? So I have a little bit, yeah. So don't forget to invite me for this, huh? Please, huh? So I have a little bit of difficulties here, and this is a very good to show that it's not every time very easy. I think one of the problem is the stricture itself. So I'm trying to be very near to the papilla. Now I will aspirate a little bit, and sometimes one of there is a lot of tips that we can do. One of them is to use so first of all, you should not use a lot of the elevator. Number two, think about using so big wheel is very important.
You pass.
Yes, I'm inside now. If you can shift to the spy image.
Yeah.
Yes, you can see the spy image. So I will go a little bit far now. I will ask yes, whoosh inside the spy. Yes. Very good. Okay, stop. So I will further. Yes, I think yes, you can see it now.
Yeah, I think now we're at the level of the stricture,
The stricture
at the top
itself.
of it.
I will manipulate a little. اغسلي كمان. Whoosh. Yes, you can remove the guide wire, Salma. So I will remove my guide wire. I think I'm on the typical. I will pull back my spy few millimeter back, and you can see this is. I think this is a very beautiful image of the mass itself on the right side here.
Yeah.
Yes, with all this typical, atypical, I will say,
Vessels. Yeah.
vessels. Yes. Yeah. So my goal will to be to put to take a spy bite from this, and then after that, so could you shift for the endoscopic? Yes. So now I will go to I will put a spy bite, and my target is to target this area with vessels, with a little bit of atypical mucosa and vessels, and then after that,
Mustafa,
yes.
Mustafa, very, very nice case, congratulations.
Thank
When
you.
you see this big vessel, does it mean cancer for our audience?
Yeah.
Does it mean that it is malignant, or you still have some doubt in your mind?
I will say this is pro the malignancy. So I cannot say, as Hany said, with the gross picture only, we cannot say, okay, this is 100% malignant. However, like the polyps, like the colonic polyps, when we see this very difficult or very irregular vessel with this very irregular vascularization, this is again pro with having a tumor. But I think again the definitive will be to do biopsy. I think maybe Hany will correct me. I think till date we don't have a very good data regarding on-site pathologists like the FMB to have someone on-site with us to give us the final conclusion. I don't think we have this.
Yeah, I think there was one study that compared doing an on-site pathology with the spyglass versus the standard, and I think it showed no additional benefit from doing an on-site pathology. But yes, so yes, Zari, as you said, so in this case, I would say to the patient, I have a confidence with this image of over 95% that this is a malignant tumor with the presence of these really typical neovessels.
I think for the sake of the time, yes, so I will just, yes, I will let you, Cesare, comment, but after the sake of the time, because we need to show you, before we finish the session, the end of the poem. So my plan today here will be to take the spy bite, put a guide wire, I will do RFA for this lesion, and then I will put a plastic stent. I will not put a metallic one. I put a plastic stent, I will wait for the pathology. If this patient is malignant tumor, I will change this with a metallic stent in a couple of days. So this will be my plan, and then yes, you can go now because I have pressure from the control room to go to the poem.